Good morning, tribe. So thankful that you're here to join us today. We have Natalie talking to us about her experience as a nurse in the UK versus the USA. So welcome, Natalie.
Hi, thank you for having me.
Yeah, I'm so glad you're here. So how long have you been a nurse in total?
So I got my degree in nursing in 2003, so 15 years, long
Okay.
time.
Yeah. So how is the nursing role different in the USA versus the UK?
Oh, well, this has been an interesting one. So, when I was in the UK, I did a variety of different roles. And certainly in the UK, until fairly recently, there has been a sort of graduated approach to promotions in the sense that I did a couple of clinical nurse specialist roles, but I haven't got my master's degree, for example. So I think that from an educational perspective, in terms of jobs, there's definitely a big difference there in terms of things need to be completed here, whereas certainly in my experience, there are promotion opportunities from experience as opposed to just what you have on paper.
Okay.
I think as well, the environment's very different because, as you can imagine, in the UK we have a national health service, and in the US everything is private. So
Mhm.
that's something that I am learning to get to grips with, and I know that you're going to talk a little bit more in your questions about what that kind of looks like, in real life. But I
Sure.
I suppose that's probably one of the biggest differences is that the systems are just so different.
Okay, so any practice differences in terms of like skills that nurses in the UK are permitted to do, but they aren't to do here in the US or vice versa?
Well, I suppose I mean, I'm not working in a hospital position now, so I think in some respects it's a little bit difficult to say that. But I know that, for example, in the US, you guys all, as an RN, do your IVs in the sense that you're cannulating, putting in your own lines. In the UK, that's not something that we would do. We do IV care, so we obviously provide all of the IV meds, TPN, all those sorts of things, giving pushes. But we don't routinely cannulate our patients. That's something that our junior doctors do. And when I've discussed it in the past with team members in the UK, they feel that that's just something that's not really a sensible use of our time, that the junior doctors need to be doing those skills. They need to be getting up to speed with those things because they'll have to use them. For example, I think you guys here tend to have IV teams in the hospital, whereas we would be calling, a consultant, so an attending, and saying, okay, X number of people have tried, can you come and do it? So it's a different system. I know certainly within PEDS, we were very regularly discouraged from catheterizing boys because there was a history of complications in catheterizing boys. So we had people who specifically would do that, namely, again, some of the more senior doctors. So there's
Interesting.
definitely a difference. There's definitely a difference in the roles, definitely.
I wonder if that difference, this is kind of off the subject, but I wonder if that difference in catheterizing boys is not castration, sorry, circumcision. Is
Yeah.
circumcision common still in the UK or is it not common?
No, it's very uncommon, certainly in my experience. For example, just thinking about my friendship group, none of my friends' children are circumcised, whereas here it's an automatic kind of standard. And in fact, and again, kind of going off subject, I noticed something, and I'm not sure, I think it was you that had put it about a recent study to do with circumcision and SIDS and whether there was a link. And actually, it created a discussion with myself and some colleagues here because I
Yeah,
thought, well, that's very interesting. I wonder what the SIDS rates in the UK are compared to here because it's not a common practice. So yeah,
yeah, that
maybe.
is really interesting.
Mm.
Huh. I wonder if there's any correlation between the issues with catheterizing and the lack of circumcision, or if that's just coincidental, not necessarily going hand in hand. It'd be interesting to look into that.
Yes, it would.
Okay, so the challenges that you faced, do you have anything specific aside from what you've already mentioned?
Well, I mean, I don't know, I guess if this is what you're referring to, but the process of transferring your license from one country to another, which I imagine if anybody is watching this, maybe where they are interested mostly, was a real headache and a very, very long process. If I can just give you a little bit of background, I actually grew up on the East Coast. I grew up in New Jersey. My father worked for a bank in New York. So I was familiar with the US system, but I actually finished my schooling in the UK and I did my degree in the UK. Okay. But I then ended up moving to New Jersey to live with my husband. And I started the process of trying to transfer my license. Now, your members who live on the East Coast will be familiar with the CGFNS, perhaps less so on the West Coast. The CGFNS being a broker who basically works with the Board of Nursing to vet any new nurses. Now, the CGFNS said that my 4-year degree, which was a Bachelor of Nursing, was not sufficient to take the NCLEX.
Wow.
And I could not manage to talk to anybody, to speak to anybody. Everybody was incredibly unhelpful at the Board of Nursing. So I gave up. And I thought, you know what? All this experience might count for nothing. And then my husband got a job posting in California. And I thought, you know what? I'll just look up on the Board of Nursing for California. It was far more clearly laid out exactly what I needed to do. I got my transcript sent again from the UK, but directly to the Board of Nursing, this time not via the CGFNS. And within about 4 or 5 months, I got my approval to take my NCLEX.
Awesome.
So just crazy. Had I stayed on the East Coast, I would have probably not returned to nursing, which would have been
so unfortunate
to me. But the irony being that now I could transfer my license to New Jersey.
Yes, there you go.
So it's crazy. It's tough. And I imagine it's the same going the other way. I imagine it's the same.
Sure. And I mean, moral of the story in your case is don't give up, right? Yeah. Like, had you just said, all right, my degree is null and void, instead you pursued it again. And I'm so glad that you did.
And I worked so hard to get to where I was. And sure. The idea that I was going to have to give them up, to give that up, even though I'm a mum to 2 beautiful little children and being home with them was amazing. I thought, gosh, this is me, So yeah, don't give up. It's possible. It's definitely.
So how's the medical system different as a whole?
So I guess it goes back to what I was saying before. The NHS is very much a system where, if I can give you an example, you take your child to the ER and the ER identifies that they need, a number of referrals to different services. All of those services are facilitated within that facility. So there is a referral made to, say, the endocrinologist or the cardiologist or the respiratory team, obviously what you guys refer to as the pulmonology team. And it's all done in-house. My understanding of not only personal experience, but also professional experience of the system here is that it's really, really hard work for your families to access services because they have to do everything themselves. So they'll go somewhere and they'll be told, oh, you need to go and see this professional. And then they're looking for who takes their insurance. Where is that professional located? Do they have good reviews? That never happens in the UK. So I'm not suggesting that the services are seamless because they're definitely not, but I definitely feel that there is more internal advocacy for the patient in the UK, as opposed to the system here being, well, what can you afford?
Sure. It's a huge difference. Mm-hmm. So if you could change one thing about the medical system in the UK, what would it be?
Oh gosh, in the UK, good question. Probably the fact that I wish that you could be more creative. I changed jobs quite a lot because I felt constrained to not be able to be more creative. I love my job now because I'm a clinical director for a company where I can, within limits, make my own decisions and be creative. I think more of that needs to exist in the UK.
So when you say you want to be creative, are they more policy driven and doctor led order following, or can you elaborate a little bit on that?
It's interesting. Yes, that system does exist, but I think being truly British, it's not perceived as, well, you are being ordered to do
Oh,
something.
sure.
Even here, I refer to it, we talk about orders within my line of work right now, and I say, I prefer to call them a request.
Sure.
So I think that, yes, it is still very much MD led. So they're the ones that sign the prescriptions, and you provide care as per their orders. But I suppose I'm thinking more of inpatient facilities whereby I'd been there a long time. Sometimes I would have liked to have been a bit more creative about how we've provided care and those sorts of things. And of course, within a big hospital, as you say, you're working within the confines of the policies and procedures.
Sure. So you probably already touched on this, but what would you change about the medical system in the US?
Oh, I just wish that there was more advocacy. I wish there was more people, because you know what? The nurses have a passion. They love their patients. They care about their patients. But I don't feel that the system enables them to truly help their patients to get the support that they need, because it's not within their ability, because it's into insurance companies. It's trying to find doctors. In the UK, one of the jobs that I did, I could really advocate for that family because we were all working within the that you can only do so much, and then you have to let the family go and do it themselves. And I think that that's a real shame, because I think that families struggle, and when you're sick, that's the last thing that you need, is to have to go and shop around for your doctor. You just want somebody to help you, right? And send you an appointment.
Yes. Yeah, we were having this conversation just yesterday, I think it was, the struggle with getting an MRI. Well, my insurance company is denying it, and I need more proof from my doctor. And, I just got off chemo. All I'm trying to do is figure out if my chemo has cleared or not, and I'm not talking about myself personally, but, as a patient, they're just trying to seek the care that their doctor has recommended. And it's all these hoops that they have to go through. And
they're sick. They're sick. They don't want to do that, do they? Whereas in the UK, you need an MRI, you'll get an appointment. Now, it's not necessarily going to be tomorrow.
Right.
You'll get an appointment, and it's not about what you can afford. It's not about what your insurance can afford. It's, I need an MRI. When am I going to have it? Tell me where to go.
Sure. And something that the USA is working on is creating care coordinators in the insurance setting. So they are trying to advocate for their patients in a sense where the insurance companies are working alongside with assigned members. They have an assigned care coordinator. And so that's a working process, but it's all still very convoluted and messy. So okay, so let's see. How was the experience in getting your license transferred, which you already addressed, but any insight or advice for someone trying to go into another country? Any steps they can do previous, or any advice that you have?
Hang on a second.
Okay.
I can get my light back. There we go. Sorry. Well, I think it depends who you're dealing with. I felt in New Jersey that I got to the point where I just couldn't even speak to anybody. Nobody would even speak to me. I just could not get anywhere. And I consider myself to be fairly persistent. Sure. Unfortunately for me, to be honest, it meant changing states to be able to get what I wanted. But equally, I didn't need to necessarily be in California to do a lot of that paperwork. So I imagine that maybe there's a way around that for people. But all I would say is just keep going, like we already said, and, make all those phone calls, find out people that that might work in the field, and try and use all of the contacts that you possibly can.
Sure. Awesome. So what are the three top things that made you nervous about the change, and how did you overcome those? Anything specific in your line of work changing from the UK to the US?
Oh, well, I mean, where do I start? So I had to do the NCLEX, and of course, I've been a pediatric nurse for 15 years. So then I'm swatting up on my maternity and my adult and my mental health. So that was definitely a big challenge. I had a newborn and a 2-year-old. So I studied during every nap time, and I stayed up till about 2 a.m. every night for 4 months. And I got there in the end. So that was a challenge. Drug names. All the drug names are different.
Oh, yeah.
That's a huge thing. Even now, I find myself, I'm like, okay, I'm looking something up and I'm thinking, okay, Omfi. And then I look it up and I'm like, oh, that's what it is, So they're all the same, but they've all got different names. So that's definitely been a challenge. And I suppose the other thing as well is trying to recognize the differences in the system and not try and transfer everything. We've all been there and done it. Well, this is what we used to do here. It doesn't transfer. It's a very different world. So that's been a challenge, but fortunately that one hasn't been too difficult to overcome.
Awesome. Yeah, I can see how you would have to, especially with 15 years experience, you would have to really be open-minded to all that change. That would be challenging.
Nursing's nursing. Kids are kids, assessment's an assessment. The same here or across the pond. You can figure out the detail. That's been my attitude to it.
Awesome. I love it. So you kind of already addressed your biggest challenges. So what do you love most about what you're doing currently here in the US?
In terms of my job? Yeah. Yes. I love the company that I work for now. I have huge variety within my day, going out and seeing patients, sitting in the office, talking to my RNs, talking to LVNs, working with a huge cross-section of people. So I love that. Also, I do love the autonomy that comes with the job, in the sense that, again, within constrictions, you can be creative. I can sort of put my own stamp on my work. And again, I adore my children. I miss them terribly. If I could have not gone back full time, I would have done anything to not go back full time. But you needed to, and this job became available. But I like being at work. I like helping people. So
nice. So you were in the inpatient hospital setting in the UK, and here in the USA, it sounds like you're doing some sort of like home health care or something like that.
Yeah, so I'm a clinical director for a home health company now here. But awesome. I was what we referred to as a continuing care manager in the community in the UK as well. And that was born out of my passion for children with complex needs, and obviously providing them with care in the community. I was on the other side, if that makes sense. So I was on the side of trying to get the funding and things like that, as opposed to being on the provider side now. But very similar in that role.
Awesome. It sounds like you found a great fit for your skill set.
I have, yes.
So what would you say the hardest part of being in home health care is?
I suppose the hardest part is understanding that you're not there in the homes all the time. We have got, 100 so LVNs who are out doing the practical day-to-day work all the time. And so to be, of the mindset that I am responsible for all of them and everything that they are doing, which essentially I am, can seem quite overwhelming. Yeah. I think if you know that your systems are robust, that your training is good, that your compliance is good, it provides you with the confidence that, yes, you're not there, but you are confident that the nurses know what their job is and that they will contact you if they need you. Of course, we have RNs here who are going out and doing the home visits, monthly, or as needed. So they're all the eyes and ears out in the community for you. So yeah, I think it's kind of accepting that you can't know everything that's going on, but that's okay.
Yeah, absolutely. Is there anything that you want to know that maybe I could answer to you? It sounds like you work with a ton of nurses from the US, so probably not, but anything that we can answer for you as a group?
Well, I mean, I suppose the only thing that I would be interested in, I know that you've been doing this sort of, I'm not sure what you would refer to them, almost like the flashcards for different specialities and things.
Yeah.
I would have loved one if there was one on common generic meds and the names and stuff like that. I don't know how anybody else would find that, but certainly transferring from one language to the other, shall we say?
Yeah, I could see how that would be really helpful for probably even a lot of nursing students as well.
Well, I think the problem is there's so many names, aren't there? So many different names people are using. So.
Yeah. And the problem is that they change so frequently. Mm-hmm. And so that's another thing that you run into creating a resource like that is that, you know, by the time it's produced, now half of them no longer exist, you know?
Yeah.
So anyway. All right. Well, thank you so much for taking the time to chat with us, Natalie. And we've learned so much from you. I appreciate it.
Oh, good. I'm glad. Take care.
Thanks. Bye-bye.
Bye.